an introduction to behavioral health crisis services, best practices in transforming crisis care. Let me advance my slide. We'll start with speaker introductions, and then we'll go on through our presentation. But I'm Amy Watson. I'm a professor at the School of Social Work at Wayne State. I've also been doing work over the past probably 20 years related to crisis response and CIT programs. And I am joined today by my colleague, Leonard Swanson from the Center for Behavioral Health and Justice, and I will let him introduce himself.
Hello, everyone. Thank you all for being here. My name is Leonard Swanson. I manage crisis response projects at Wayne State University Center for Behavioral Health and Justice and its School of Social Work. And we do evaluations and research along the whole kind of criminal legal continuum as it relates to behavioral health services. But we, or at least I, specialize in crisis programs, which we'll get into in the next hour or two. Thanks, Amy.
All right, thank you. So just some quick housekeeping. If you have questions as we go along, feel free to put them in the chat, but we will hold them until the end of the presentation just to make sure that we have time. And again, if there's questions we don't get to, we can try to get information to people later. So just to give you a quick overview, tonight we'll talk a little bit, we'll start out talking about definitions of behavioral health crisis, and then move into talking about components of a comprehensive behavioral health crisis system. Also, we'll touch on what people who use crisis services say they would like in crisis services. And then Leonard will talk about the work that he's been doing with CBHJ, looking at the crisis response services in Michigan. So I'll start out with a little bit more of an overview, kind of at the national perspective, and Leonard will zero in and talk about the work they're doing specific to Michigan. So I want to start just by talking about the definition of behavioral health crisis. And this first definition is just sort of commonly used definition that really starts out by talking about a crisis as a situation where someone's at risk of hurting themselves or others. And if you Google what is a mental health or behavioral health crisis, you'll often get this. It's somewhat of a narrow definition that really focuses first on risk, although it does acknowledge that people may be having difficulties functioning as well. Thinking about a broader definition of crisis, and this is a definition that I like better because it takes into account a broader range of distress that people may be experiencing. I think the first definition is something that I would call more of a behavioral health emergency, which is a subset of crisis, a particularly acute level of crisis. But if we're thinking about a broader definition of behavioral health crisis, it really is a stressful life experience or a reaction to an experience that really impacts someone's ability to cope or function. It overwhelms somebody's coping mechanisms, and it can be caused by a number of different factors. It could be a traumatic event, some type of transition or developmental stressor. It could be a psychiatric emergency or some response to a disaster. But really what it does is it creates some disequilibrium for a person where they're really experiencing significant distress. It may impact their behavior. And resolving the crisis really means restoring someone to equilibrium and really getting to the point where they've got some mastery over the situation and develop some new coping skills. And so thinking about different definitions of crisis, depending on how you define what a behavioral health crisis is, it's going to impact what types of service system you might design for that. And we'll talk a little bit about that as we go. So first, this is a figure that actually is from a publication that Dr. Deborah Peinels put together. And the full citation is at the end of the PowerPoint. If people are interested in locating it, it's available online. But basically, this is what I would call a problematic crisis system, but it's what traditionally many communities have had. Sorry about that. And what it starts out with is just some type of crisis that leads to a community concern. In many communities, the only number to call for a crisis is 911. Oftentimes it's clinicians that have voicemails that say, if this is an emergency, hang up and call 911. And when you call 911, you traditionally will get law enforcement. Law enforcement has very limited options to resolve a crisis. They may take someone to an emergency department, or they may arrest the person and take them to jail. Or if they don't do either of those, they may simply leave the person in the same situation without having that many options in terms of really providing support or resolving the situation. So in communities where this has been kind of what the crisis system has looked like, and I think there still are some communities that's really what we're limited to, although we're moving towards more comprehensive services. But there's been some really negative impacts of this approach to responding to crisis. For one, we know that police spend a significant amount of their time handling calls involving people with mental illness. We also know that almost a third of people with serious mental illness in the US have police involved in their pathways to care. And I can't really think of any other health condition that's the case. We know that at least 1 in 4 individuals that are fatally shot by police had a serious mental illness. And among those shot and killed by police, those with a mental illness were more likely to have been shot and killed in their homes and less likely to have had a firearm. If people with serious mental illness are arrested in police encounters and enter the criminal legal system, they tend to stay there longer. They get longer sentences, they serve more of their sentences, and if they're released on community corrections, they are more likely to have that revoked due to technical violations. So once they enter the system, they really become jammed up in the system, and it's much harder for them to get out. And we know that a disproportionate share of the burden of this problem is shouldered by persons in communities of color. So thinking about a crisis continuum that addresses our broader definition of crisis and really looks to respond to people not just experiencing behavioral health emergencies, but a broader set of behavioral health crises. This is another figure from Dr. Pinell's publication of a model crisis continuum. And it starts with someplace for someone to call before they reach a crisis level. And that could be a warm line where they're able to call and talk to someone, perhaps a peer provider, and they may avoid a crisis situation altogether. However, if the crisis reaches the level that either the person themselves dials 911 or somebody else does in a comprehensive crisis system, one, they may have someone besides 911 to call, but if they dial 911, that emergency communication center may have the option of transferring the call to a crisis line, sending a mobile crisis team, or sending a specially trained police officer, perhaps with a clinician, to provide a response. And of course, a model crisis continuum would also have options beyond the emergency department if the person does need to be transported to a facility for assessment and stabilization. That could be a crisis stabilization unit, and other types of clinics. So again, thinking of that broader definition kind of really leads us to thinking about a more comprehensive set of services that we would provide. And while the figure that I just showed is pretty busy, it's really actually somewhat simple. And the Substance Abuse and Mental Health Services Administration kind of breaks it down into 3 components of a crisis continuum. And that's a regional crisis call hub or someone to talk to, mobile crisis response team, which would be somebody to respond, and a crisis stabilization center or crisis receiving facilities, which would be someplace to go. And this figure comes from a publication of the National Association of State Mental Health Program Directors that Dr. Margie Balfour developed. And they looked at kind of the crisis system and the alignment of services and created some estimates of of the flow of cases through these different components. And it starts out with a person in crisis who may call a crisis line, who may dial 911 and have the call transferred to a crisis line. And they estimate that about 80% of those calls can be resolved on the phone, with, de-escalating the situation, helping the person come up with a plan, and linking them to services. Of the 20% that aren't resolved on the phone, a mobile crisis team can be dispatched. And again, about 70% of those situations will be resolved by providing crisis stabilization in the community. And then again, moving on, those that are transported to a crisis facility, about 2/3 of those individuals will be discharged into the community, while the remaining may end up being hospitalized. But again, if you go through the continuum, if you provide this access to these less restrictive services early on and moving through, you can avoid many of the more restrictive and definitely more expensive service options. So I'm going to go through the different components of the system and give a little bit more detail. Many of you are likely aware of 988, which is the national crisis line. It was launched in July 2022, and it's a 3-digit number to reach the National Suicide Prevention Lifeline, which has actually been in operation for, I think, about 15 years. But now you can dial 988 and reach that call center. It's operated by Vibrant Emotional Health, and they have basically, when you dial 988, it goes into their system, and they then route it out to local call centers based on the area code of the caller. So it's not geolocated. So if you have an area code on your cell phone that doesn't correspond to where you currently are, there could be some mismatch of the routing, but you will be routed to a local call center. And depending on the state that you're in, some states have multiple local call centers, other states have a single call center, but it'll be routed out to those call centers. 988 can also be accessed via chat and text, and most of the chat and text contacts are going to a national center, although states are starting to pick up, some of the state call centers are starting to pick up some of that volume. So those will be answered locally as well. The goal is that 988 call centers will have the ability to link callers to mobile crisis teams and other services as needed. So depending on if the call center may be housed in an agency that also operates mobile crisis teams, so they may be able to directly dispatch, or if they're a call center that's not housed within an agency with mobile crisis teams, they would then reach out to the corresponding agency with those teams to link callers that need that type of response. Also, what SAMHSA would like, and they've been working on developing resources for, is to have interoperability with 911, so that if a caller dials 911 and it's really more appropriate for the crisis line, that 911 call centers will be able to transfer calls to 988. That's operational in some communities. Other communities are struggling with getting that up and running. If you do dial 988, you have some options as well to have services specific to veterans, Spanish language services, and more recently, starting in July of 2023, the LGBTQI+ subnetwork was launched, and then subsequently in September, video American Sign Language option for people that are deaf and hard of hearing became available. So there's a variety of options, and they're really working to make sure that there's pretty universal access for people that may need to access crisis services. So there is some research on the National Suicide Prevention Hotline and other crisis lines that do suggest they can be very important for assisting people and reducing suicidality. There's not much out yet about 988, simply because 988 hasn't been operational for that long. But just a couple weeks ago, a study came out in JAMA Network Open, and it was a survey of a representative sample of adults in the US. And they found that less than half of the adult population had ever heard of 988, suggesting that there's still some need to make sure people are aware of 988 as a resource. They also found that the people that scored as having moderate to serious distress were more likely to be aware of 988 and have used it. So potentially they were already connected to services and they learned about 988 there, or they were just more aware of it for other reasons. One thing that was a little bit disappointing is that less than a third of the people that had scored as having serious distress that had used 988 indicated that they would use it again. So it looks like there's certainly some work to kind of dig deeper into that, to make sure that 988 services are really experienced as supportive and people are willing to access that service when they need it. So I'm going to move on to the next component, which is someone to respond. And there's a variety of different models that have been used to provide response in the community to someone experiencing crisis. They kind of go along a continuum in terms of the level of law enforcement involvement, going from the crisis intervention team model, which is typically specially trained officers that respond, moving all the way to community responder and mobile crisis teams that can partner with law enforcement when needed, but don't typically require law enforcement involvement. So the first one I'm going to talk about is the crisis intervention team model. And Michigan actually has several really robust CIT programs. And if you've heard of CIT before, you've probably heard about it as a 40-hour training for police officers, which is true that it does include that. But the model really is based on partnerships with law enforcement and other first responder agencies, community providers, advocates, family members, and people with lived experience of mental illness. And these partners come together and they first look at kind of what their crisis system looks like, and then they partner to actually develop and provide the training for officers who, according to the model, are officers that are vetted as being well suited for crisis response and that volunteer to go through the training and be identified as officers that should be dispatched. In practice, many agencies are mandating CIT training, although it doesn't necessarily get them the benefit that they're hoping. But the original model was really for those specialist officers and then having them identified as the resource to go. The model also includes making sure that there's a single point of entry for emergency psychiatric care that's identified within the community. And really what keeps CIT programs going strong is work to maintain those partnerships over time, to make sure that the different agencies and partners are working together and can address any problems. So there's been some research on CIT. There's been some really good work that's been done by Leonard and his colleagues at CBHJ before I arrived at Wayne State. I've also been involved in some CIT research as well. And there's pretty strong evidence that CIT training does improve officers' knowledge and attitudes and use of force preferences. There's good evidence that CIT training and program implementation increases linkages to care. So officers are more willing to take people to crisis stabilization centers. Some work that CBHJ did looked at it, and the CIT trained officers are willing to travel farther to get people to the correct resource. And so that's been a very consistent finding across multiple studies and multiple communities using different methods. The evidence related to the impact on use of force and arrest is unclear, with some studies finding reductions in use of force and arrest and other studies not finding an effect. There's also some evidence that the availability of mental health resources matters. CIT programs are more successful in communities that have at least some that have more resources, so officers have more options for connecting people to care. There's also an indication that the training of call takers and dispatchers can be important components of the program. The next model is a co-responder team model. And typically these teams involve a pairing of clinicians and officers to provide crisis response. They tend to have similar goals to CIT in terms of reducing arrests and increasing safety, as well as reducing emergency department transports and increasing linkages to care in the community. There's a lot of variation in how these teams are implemented. What I see most often in the US is that it's an officer and a clinician that ride together in a police car. But in some communities, the officer may arrive on scene and then call out the clinician, so they don't necessarily always arrive together. There's also variation on when they respond. In some communities, the co-responder team is dispatched as the first response to a mental health crisis calls, and in other places, there are secondary response. So you have the initial officer arrives on scene, determines that the call is appropriate for the co-responder team, and then calls them out as a secondary response. We have a growing body of research evidence on co-responder teams. There's been a couple of systematic reviews and additional studies since those reviews. But generally, findings suggest that they do improve some collaboration between police and mental health. There's some evidence they may reduce emergency department transports, but increase admission rate for those that are transported. So when you have that clinician on scene, the clinician is able to do an assessment and make a determination about whether the person actually needs to go to the hospital. Where if it's an officer without the clinician support, they may not feel comfortable making that decision. So they'll transport the person to someone who is qualified to make that decision. There's also some evidence that co-responder teams could reduce repeat calls for service by making sure people are connected to care in the community. One study saw a reduction in the risk of arrest. Another study, quasi-experimental study, found that in suicide threat calls, co-responder teams used less force than officer teams, only teams. Also, there's evidence looking at the preferences of people that use crisis services and their family members that the co-responder teams are preferred over police alone approach, that people prefer to have less police involvement in their crisis call. So next I'm going to move on to approaches that don't require law enforcement involvement. The first one is mobile crisis teams, and they've also been around for quite some time. Although, again, if we're using our first definition of a behavioral health crisis, what I've seen in a couple of states that I've lived in is that mobile crisis teams are very limited in capacity, and they primarily will serve the role of going out to assess someone to see if they need to be involuntarily petitioned to the hospital. Oftentimes, some of these teams, they can only send one person out at a time because of resources and billing requirements, and therefore they're not willing to go out into the community and primarily will go to hospital emergency departments, police stations, and schools. But thinking about our second definition of crisis, and this is the definition that really SAPSA is really looking at in trying to develop more robust and comprehensive services, really having mobile crisis teams that do much more. They'll go out and provide screening and assessments, but also provide crisis stabilization services to the person in the community. These teams often will include a peer support specialist. They'll do follow-up and crisis planning with the person that they're responding to. And per guidelines that SAMHSA has put out, they have a crisis services toolkit, which I put the link to the full toolkit at the end of this presentation. Their guidelines indicate that a mobile crisis team should have a credentialed clinician and incorporate peers. They should go out and respond where the person is. So not limiting response only to certain locations, but going to people's homes, going out into the community where the person in crisis is located. The guidelines also indicate that people should only be transferred to facility-based care when necessary. and that these teams should respond without law enforcement accompaniment unless special circumstances warrant inclusion in order to support a true justice system diversion. So SAMHSA is really pushing teams to build the capacity to go out and respond in the community where the person is, and to manage these situations without law enforcement unless there's specific risk factors present that would prevent them from going out without law enforcement. So while mobile crisis teams have been around for a long time, there's surprisingly limited research on them, but what does exist suggests that these teams can increase connections to services in the community. They can reduce pressure on the health system via reductions in emergency department visits. Similar to the co-responder teams, having that clinician on scene to make that assessment, and then get the person connected to care in the community. There's also some evidence that they can do a better job making sure that people get connected and stay connected to care in the community than just sending someone to the emergency department. So it seems to be a better approach to actually getting people connected to care. Given the reduction in ED visits, they save money. If you look at the research on mobile crisis teams for youth, the findings are quite similar. But one of the really common themes that we've seen in the literature and anecdotally as well is that mobile crisis team programs often aren't available 24/7 and they have long wait times. So if people are wanting some type of response, waiting 6 hours may not be something that they can tolerate, and they may end up dialing 911 and getting the police instead. The other thing of note is mobile crisis teams are typically not dispatched by 911. They're usually accessed through a crisis line number, a direct line to an agency. So they're accessed a little bit differently than the police-involved responses. So the final someone to respond are community responder teams, which this is kind of a new phenomena in the US. Subsequent to the murder of George Floyd, we've seen a lot of attention on reducing the footprint of police in mental health crisis calls and other types of situations that don't require police presence. And this is just a map of some of the community responder programs in North America, and it comes from a website that was put together by Jamie Livingston, who's a professor, I think in Nova Scotia at St. Mary's University. And it's a really great website. If you're interested in co-responder teams, he has a lot of resources there about them. But I'm going to talk a little bit about a couple community response programs. And many of you may have heard of Cahoots. They got a lot of press a couple years ago, and they're a community response team that's been operating in Eugene, Oregon, actually since 1988. So they've been around a long time. And they're a partnership between a community mental health agency and the Eugene Police Department. They're paid for out of the Eugene Police Department's budget. And their teams consist of a crisis worker, which is typically a bachelor's level crisis worker. But some of their crisis workers may not have a bachelor's degree. They look at experience as well. And then they're paired with a medic who could be an EMT or a nurse. They're integrated into the Eugene's 911 system. So they're dispatched directly from their emergency communication centers, and they're on the police radio. So the dispatch center always knows where they're at. And if they do need support from EMS or police, they can radio in and get that immediately. All the services that they provide are voluntary. So if they are responding to someone who is unwilling to accept support, but they're clearly at a risk of harm to themselves or others, the Cahoots team will call in a different team that has that capacity. And if the person consents, the Cahoots team members will stay with that person and at least help them navigate and know what to expect in that process. There's been some analysis by the Eugene Police Department that has looked at the Cahoots program. And in 2021, they responded to about 18,000 calls that were dispatched directly to Cahoots teams without law enforcement or any other responders. And of those calls, only 2% required any type of police backup. So, and only 2% of the calls did the team get there and say, wait, we need some support here from law enforcement. And sometimes it was because of a safety risk. Sometimes it was for something completely different, that perhaps the person they were responding to reported that they were a victim of a crime or something to that effect. They estimate that overall, 5 to 8% of all calls for service to the Eugene Police Department are diverted to Cahoots, saving some time and resources on the police side. A more recently launched program is the Denver Star program, and that was launched as a pilot in June of 2020. And has since been expanded beyond the pilot. But their team's mental health clinician with a paramedic or an EMT. They respond to low risk calls where individuals aren't at imminent risk. So it could be trespass calls, welfare checks, intoxicated people, or mental health crisis. They often respond in areas where there's calls about someone who may be homeless that is someplace that somebody else doesn't want them to be. And if police go out, it could often end up in an arrest for trespass. In their first year, they responded to about 1,400 calls. They report no injuries, no arrests, no need for police backup. So they've determined that their triage system has allowed them to safely go out without police and make those decisions. There was also a study that was done by Dean Pine, where they looked at the first 6 months of the operation of the program in the pilot districts, and they looked at misdemeanor crimes reported in that 6-month pilot period and in the 6 months prior to the pilot. And what they found was a 34% decrease in misdemeanor crime reports during the pilot period. So basically, during the pilot period, they had a different response. If a call came in, the STAR team could go out, and instead of defining the situation as a crime and making an arrest, they defined the situation as some type of social need, and they provided support and services. So, we still have to wait and see how the data pans out, if it also leads to reductions in any types of contacts as people are connected to services. So across these different models of response, there's a number of important variations in terms of how they're accessed or dispatched, who actually responds and what combination of workers responds, what their options are if they need to take somebody to another location for services. There's also variation in terms of where services are housed. So the ones that are police involved generally are housed within police agencies. Our mobile crisis teams are generally housed within mental health agencies, but our community responder teams, what we see examples across the country is they really vary where they live. Some are embedded in police agencies, some are in fire departments as part of the EMS system, and others are connected to mental health agencies. The other variable is who pays, and particularly if it's police involved, typically it's just part of the police budget. If it's a mobile crisis team, it would typically be your Medicaid or moving towards being able to bill private insurers as well. The community responder teams are really quite the mix, with some of them developing the capacity to bill Medicaid at this point, but oftentimes they're paid for out of either the police budget or other city budgets. So I'm going to go to the last component, which is someplace to go. And this is typically crisis receiving centers and stabilization units. And this is just a picture from one of those. This may be, I'm not sure which crisis stabilization this is, but they're often spaces that try to be welcoming and relaxing and not as chaotic as an emergency department. And SAMHSA in their toolkit has established some minimum guidelines for these crisis stabilization centers. The first one is that they accept all referrals. So not rejecting people because they might be intoxicated or have a criminal history. So they really want these stabilization units to develop the capacity to accept people with a variety of different needs and behaviors. They also can't require medical clearance prior to admission, but rather have the capacity to do that assessment in-house and have the capacity to provide support for some basic minor medical needs, so that people don't have to go to an emergency room before getting to the crisis stabilization center unless there's a serious physical health challenge that needs to be addressed. These crisis centers need to be able to address both mental health and substance use crisis issues. So if someone comes in intoxicated, that they have the ability to accept and provide support for that person, as well as someone who's coming in with just a mental health crisis that's not substance involved. These centers should be 24/7. They should have multidisciplinary teams and have a variety of services and the capacity to do suicide and violence risk screening and assessments. An example that I know a lot of programs, a lot of communities are going to visit actually is the Crisis Stabilization and Receiving Center in Tucson, Arizona, which I think is maybe one of the first of its kind. But Dr. Margie Balfour it runs the center, but what she talks about is that they're a no refusal center. They also have a separate drop-off bay for law enforcement. So if police need to bring somebody to the center, they can drop them off and get back out on patrol pretty quickly. And they have in-house capacity to address a variety of physical health needs. They also have the capacity to provide support for someone who may be combative or have some violent behavior. So their philosophy is that these folks coming in a behavioral health crisis are people that their system serves, and they're not going to come up with reasons to deflect people to other types of services. I just want to also make a note on, well, actually, back in terms of crisis stabilization centers, there is a little bit of research that suggests that people that are pretty acute that would normally go to the hospital can be safely served within these crisis stabilization centers, and their outcomes are at least as good as people that are served at the hospital. So there's some evidence that these are an effective alternative to utilizing the emergency department. Okay, so now I want to just touch on certified community behavioral health clinics and crisis care. And these are specially designated clinics. They're federally funded. It's flexible funding to help expand the scope of mental health services and expand access. And CBHCs, some states have really accessed this flexible funding and are further along in establishing CBHCs. Michigan is one of the states that has done a Medicaid waiver in order to establish some. Other states are more at the stage of getting grants to do some planning to establish CCBHCs. However, the CCBHCs are required to serve everybody, regardless of insurance, diagnosis. They have some very specific timeliness standards. So if people are experiencing crisis, they have to provide an immediate response. For less immediate needs, they have to provide care, some type of initial care within 10 days, which is rocket speed, I think, in terms of access to services. They also have to make sure that they do provide access to a variety of crisis services. So all the different services that we've talked about so far. They need to partner with other crisis entities, including law enforcement, and coordinate with 988 as well. So again, this is another resource that has some mandates around providing crisis care as well, to sort of add to the continuum of services that we have available for crisis care. And I'm going to end sort of my part of this before I pass it on to Leonard. I think it's really important if we're talking about kind of crisis services and particularly the work that's going on right now to really transform and build a more robust crisis system, is that we also need to think about what do people want, the people that might use these crisis services, what do they want in crisis services? And I've done some work with a couple of colleagues from Columbia University where we did interviews with people that have had experiences with the criminal legal system as well as crisis services. And we interviewed them, and for some of them, they brought in a family member. We interviewed their family member. And overall, they really indicated that they prefer a reduced role for police in crisis response. Preferably, for the most part, they don't want police involved at all. Although both the people that had used crisis services and family members did acknowledge that sometimes there is a role for police due to safety issues. We also had a few people that said that they preferred police over having a mental health clinician respond because they associated having the mental health clinician there with an involuntary commitment order and an unpleasant or coercive experience there. And what that tells me too is that not only do we need to work on creating services that don't require police, but we need to make sure that those services are really designed to be the least coercive and really respond to the needs of people that use those services and provide support. People also told us that they preferred care in the community over emergency department care. And when thinking about what they'd like provide, that the provider attends to that. They want the providers to provide choices and options to people and to be transparent. They want kindness, courtesy, and respect. They want the option to include family and friends. And they also really desire follow-up care. So I think, again, when we think about what these services are looking like, really centering the needs of the people that are serving is really important. And I think with the guidelines that SAMHSA has provided, and they are providing some grants to help communities develop services along those guidelines, I think they're trying to incorporate those perspectives as well. So now I'm going to hand, I guess, the cursor over to my colleague Leonard, and he's going to talk more specifically about crisis services in Michigan.
Thanks, Dr. Watson. It's an honor to follow you. For anyone who doesn't know who Amy Watson is, she's a big deal in this field. So it's we're lucky to have her not only here at Wayne State, but in the state of Michigan, but also on this webinar. Always learn something from Dr. Watson, and that's true again today. So who am I? What do I do? What do we care about this stuff? So I work here in the state of Michigan. I live in Kalamazoo, but I work at Wayne State University, which is in Detroit, and we do evaluation, research, and technical assistance across the state, or as much as or across the state as we can. So we work with a lot of different local agencies. So whether that's the mental health agency, could be law enforcement, could be dispatch, could be jails. And we do research evaluation kind of sitting in between all of those agencies to kind of collect data and facilitate conversations so that people with mental health issues and substance use disorders can get better treatment or treated in a more humane way in the criminal legal system and before it as necessary. And so what's nice about not sitting and eat in any of those agencies, but sort of sitting in between those agencies is we can kind of be the third party that can speak with an objective voice. We can bring evidence-based practices to our local communities, and we can kind of make recommendations without getting sort of involved in the local politics that can come up from time to time. And it's also nice to move between communities, between a lot of different communities, to kind of hear how things are going on a practical level. We often hear that if you know one mental health system, you know one mental health system. If you know one law enforcement agency, you know one law enforcement agency. So we decided as a center, let's get to know 39 different agencies and see what the common threads are among all of these different systems, and see what are the main kind of pieces we can learn and bubble up across these different communities, and then also up to the state as well. So one of the fun things we do is we hear about some exciting and innovative evidence-based and promising practices, and then we help communities try to implement them. So sometimes that's in jail diversion, where you see a number of different counties listed there, and to the left of the map, of helping people get better connected with mental health services in jail. We've done a number of opioid treatment projects, treatment ecosystem projects, including medications assisted treatment in jail, and some post overdose response program implementation as well. We do some juvenile justice work in a few counties, and then reentry after prison. And then the field that I've been working on is crisis response. So you can see kind of the number of different places that we've worked. So we are a research center, but we also try to be really community engaged in how we can develop reports and projects that really inform local level decision making to get people the care they need and avoid the criminal legal system. So that's kind of the background of where we're doing our work and how we're doing our work, and I'll show you some of the work. So next slide. So a piece I want to underscore that Dr. Watson talked about a lot of these different models, right? So there's mobile crisis, there's co-response, crisis intervention team, and community response, right? And so basically repeating a lot of what Dr. Watson said, but it bears repeating, right? Because one thing social workers are good at is helping people. Well, one thing we're bad at is branding. So I hear these terms get used in so many different kinds of ways, like CIT. I've been heard using as, is it just a 4-hour model, or you did any kind of training? Is it just the training, or is it this broader team? Mobile crisis, does that mean you're bringing law enforcement? No, it doesn't. So we created this figure to help differentiate what these models are and kind of where they fit. So I'll kind of talk a little bit about what's going on with this. So on the left side are these kind of non-police models that Dr. Watson was talking earlier, right? We see the mobile crisis, community response. There's no law enforcement there. And if you're familiar with the sequential intercept model, it's kind of a technical term for those in the sort of behavioral health and justice space. You can see the intercepts at the top. So intercept 0 meaning there's no law enforcement. Intercept 1 meaning there is law enforcement. And so on that right-hand side, you see the law enforcement-based models with co-response, meaning mental health professional with a law enforcement officer. And then the bottom right, we have the crisis intervention team, which is broader community collaboration, but also involves sort of a law enforcement 40-hour training. So there's colors going on in here too, right? So blue, I indicated for the traditional law enforcement system. So you see the 911 call, and you see 911 in there, you see law enforcement, you see behavioral health and high risk. Green generally means the mental health system. If you didn't know, another piece that we're not very good at branding is green is the official color of mental health systems. So if you didn't know, now you know. So look for green there. But there's another kind of indicator of the mental health system, and then red I sort of indicated as EMS or emergency responses, though not always, but as a general rule. So 3 kind of main questions that we use to differentiate what these models are. So how do the calls get to one of these models? Who is actually responding to the incidents, and then what kind of calls are they going at? So I'll start on the kind of top left quadrant of mobile crisis. So they almost always just get their calls from crisis lines. So sometimes that's 988. I've heard some states work that out, but in Michigan, we haven't really figured out that 988 to mobile crisis piece yet. So it's usually the kind of internal line that the community mental health agency runs, which is sort of the public mental health agency that receives this state funding in local areas. Almost always involves a clinician going out, as well as either a peer or a mental health technician. The name of the other role can vary depending on what county you're in, but it's almost always a two-person team, and a clinician is usually there too. Sometimes just in a supervisory role in the background, but usually what we're seeing in Michigan is the clinician is going out there as well. And what kind of calls? We wrote behavioral health and low risk of active violence. So by behavioral health, I want to underline the point Dr. Watson made earlier, that they're really focused on these calls of whether hospitalization is necessary, whether this person needs to go to an emergency department or inpatient level of care. It's for the community mental health system, it's a bit of a money saver, right? So if you're able to de-escalate folks on scene and avoid the higher acute care, the community mental health agencies are going to be sort of geared toward that question, more so than sort of the basic social needs questions that community response models to. But low risk of active violence, meaning if there's any weapons on scene or if there are any threats to someone or others, I would be surprised if mobile crisis teams go. That can differ by the site, and we'll get to that in a few slides later. But usually they'll go to low risk incidents. So on the top right quadrant, we have co-response, and by co-response, I mean a mental health professional and a law enforcement. You can kind of see that green and blue kind of split in the middle. Whether sometimes that's a clinician, sometimes it's actually almost always a clinician, especially in Michigan, with the law enforcement agency. Sometimes they get calls through a 911 where they can call out the co-response model, but sometimes there are dangerous calls that come through crisis line where the mental health agency determines that a law enforcement presence would be necessary, and then mobile crisis shows up on the scene alongside a law enforcement agency or an officer. So some calls do get routed there if the person poses an imminent risk to themselves or others. And that kind of underscores what kind of calls they attend to, right? We're talking about behavioral health incidents. A lot of the cases they start to go into in Michigan are suicide calls. If someone has a weapon on them, or even sometimes they don't, but generally high risk calls where law enforcement are needed. In the bottom right quadrant, there's a crisis intervention team. So this is the most prominent model of police training. It's crisis intervention team is more than just training. It's a community collaboration at a local level with mental health agencies, sometimes emergency departments, law enforcement. But the training aspect of it is 40 hours a model. It is a law enforcement model, so it's if you say CIT, it's unusual that someone's referring to a clinician or a mental health professional. The calls that they go to are straight 911, and they respond to generally a high risk of active violence. That's probably the most common model that we see across Michigan right now. And then the bottom left quadrant, community response, we actually don't have any of these models in Michigan right now. I mean, Dr. Watson listed a couple with Cahoots and the Denver Star model and a few others that are popping up recently, but this is something I'd like to see more if we can get it going. I've heard a group in Ann Arbor is trying to get that model going. I think in Ypsilanti as well, but as far as I know, it's not going yet. So these kind of models, they get their calls from crisis lines, or like sometimes they generally have their own line that you can call and say, hey, I want Cahoots. Can Cahoots come out to me? That's one option. And then they can also get their calls through 911. Often have, it's not quite a clinical level, but a service coordinator level. And sometimes they also have an EMT or a medic. And their scope of their calls is a little broader than mobile crisis. Again, this is all what Dr. Watson said, but bears repeating. It's a broader scope. If someone is, for example, swinging bags in the middle of the street or pushing a wheelchair into traffic, or a business is concerned, or what's a nicer way to put this, has an issue with someone panhandling outside of their business. These calls are really low risk of active violence, where you don't quite need or in my opinion, you wouldn't quite need a law enforcement presence there, but there probably is some behavioral health issue in the background, but it's not sort of the forefront of why you need a team there, right? You don't need a clinician to diagnose whether this person is going to pose a threat to themselves or others, but you need generally someone with empathetic empathetic skills, de-escalation skills, and is well connected to the community resources to build rapport and connect them to social needs and services around. Right, so lots of models, and I'll keep bringing these up in the next slides. You can switch the slide. Yep. So here are a list of the models that we know about of co-response and mobile crisis here in Michigan. And a lot of these have been popped up in the last few years. So if you're familiar with our state, if you're familiar with different cities and counties, so on the left-hand side are cities and law enforcement agencies with co-response models. Usually, and these are listed on the city department side. Some of the different police agencies hire their own clinician or social worker, and some of them partner with their local mental health agency to do that kind of co-response. And I'll say this is a huge growth in this kind of model in just the last 3 years, really since the murder of George Floyd. So actually, as I look at that list, I can only spot maybe one of those cities, maybe two of those cities that had co-response model 5 years ago. So a lot of growth happening locally really recently, which in my opinion, pretty promising. We see a lot going. I see some articles that like what happened with the Black Lives Matter movement, or what happened with these kind of large national movements. And there's a lot of protests during COVID that we want to see this huge change, and really this is a local and state level change. It's not really a national level change that you might see in like the CNNs and the New York Times or the MSNBC or the Fox of the world, right? We're not going to, like, these are kind of local city level and sometimes state level policy changes, and just because of how the like police agencies are structured, just because of how mental health agencies are structured. So if you're really interested in kind of seeing that growth in these response models, I encourage you to find some local outlets to see that the change is bubbling up here. And then on the right, you'll see counties with CMH mobile crisis teams. And so by CMH, I mean the community mental health agencies, which receive the public dollars for mental health services here in the state of Michigan. And there's a few of these agencies kind of see a number of these counties. And again, there's been a lot of kind of growth here. And so I'd say, so youth mobile crisis is sort of a mandated service across Michigan, right? There has, state of Michigan, I think it was about 5-10 years ago, I think closer to 10 years ago, they mandated youth crisis services have to happen. So this, by these counties on the right, is mainly adult mobile crisis systems. And by mobile crisis, I mean, it's not just going to an emergency department or a jail, but it will actually go out into the community. And so the way to get in touch with these is if you know your local CMH number, and they often have a crisis line to call to get in touch with them. I think that's all I want to say about that. Yeah. So this is not a complete and exhaustive list, right? These are just the ones that our center knows about. It's possible that more exist. And if you are home to any one of these places and you have trouble either getting in touch with them or want to learn more about it, send me an email. I can get you in touch with someone in any of these cities or any of these counties, or at least I'll do my best. I've got someone to try. We can go from there. Okay, next slide. Okay, so we've been talking about crisis response programs, but it's also important to know the systems that they're a part of, right? So Dr. Watkins showed a few different process maps, and us researchers, we love process maps. We love to figure out, okay, you have this program, but how does it fit in the larger kind of scheme of what's going on in your local area? And why they're so important is they're so different depending on what county you're in. So like I live in Kalamazoo County, and even just, I don't know, 50 miles north up in Kent County, completely different crisis system. You have a completely different set of resources, right? I'm someone who like spends all of my time thinking and researching this stuff, and I like kind of have an idea of what's going on with all of these different counties, right? And so I'll do my best to kind of show you the local level differences, but I just want to underscore, if you know kind of one county or city system, one system. So what we try to do as a center is we help communities get to know their own crisis system, especially if you have a job in crisis services at like law enforcement or mental health, because oftentimes they don't know what the other agencies are doing. And so it's good to kind of put all of the resources on kind of one page or one whiteboard and try to draw the arrows of how these different pieces connect. So if you want to click to the next slide, I'll show you a little bit about what that looks like. And I'm not expecting you to read my terrible handwriting, but this is like the messiness of this is sort of the messiness of crisis systems in general, right? So at the top on the board, you'll see call, respond, go. So that echoes the SAMHSA language that Dr. Watson referenced earlier, right? Someone to call, who are the different places in your community that you can call when you're in a crisis. A lot of times it's 911, sometimes it's 988, sometimes it's the community mental health crisis line, right? Who are the different responding agencies and who is willing to go to what kind of calls. So we kind of list boxes there, and then places to go if you're in a crisis, right? Where are the facilities? There's emergency departments, there's community mental health offices, there's shelters, all sorts of different options there. And so what we do as a center, we get a number of people in the same room, whether that's the CMH, there's the law enforcement, there's dispatch, there's hospitals. Sometimes we've had universities or shelter agencies. Anyone that kind of is in, or sometimes we have like the school board because they see crises all the time and would like better connections to the other crisis resources in the area. So try to get everyone in the same room. We get them lunch, so they're a little happy with some free lunch, and then can talk about what's going on. Sometimes we get a little bit under there's like nice lofty descriptions of like yes we'll see we'll go out to the community no matter what, and then the really interesting part is like when they're like that's what you say you do, but that's not quite what happens when we go and practice. And that's the really good stuff that we like, because then we start to get okay, what's actually where is the rubber where is the rubber hitting the road, where can we get traction, where do we actually need to work on the system to make it flow a little bit better, and how can we address some of the sticking points that are going on, which is really helpful as sort of this kind of third party agency. Like if we were worked for a police department or like worked for a mental health agency, there would be some of those political dynamics. And so as a third party, it's really nice to kind of be in the middle and kind of play dumb and be like, okay, how does that really work for you? And it's really nice and fun. So anyway, so it's basically a mechanism to look at what's going on in a local system and try to get folks to vocalize what their challenges are. So it's clearer than this, I promise. Dr. Marvins, if you go to the next slide, we can show kind of some editing work we did in this. So I've got 3 different maps. I don't expect you to memorize everything that's going on here, but just to give you a sense of the different pieces that are often going on local level crisis systems. So this is a particular city that we mapped about a year ago, maybe less than a year ago, where we broke it out into different places to call. So you see that someone to call, that's someone to respond, and a place to go. So and you see the individual and crisis in the top, and you can kind of imagine someone flowing from the top of that diagram down to from a call center to different response centers to places to go. Right, and there's obviously some parts of the map that we would like to see, and there's parts of the map that we're trying to avoid, right? We want to have fewer arrests, fewer traditional police responses when as possible, bearing safety and concerns of all that, and kind of fewer 911 calls. And we want to try to shift calls as much as we can in a safe way possible to this kind of mental health system, which is kind of more on the right-hand side of this chart as well. So you'll see a few of the options that we've been talking about earlier, right? 911 dispatch often gets a lot of calls. I think Dr. Watson said was about 10-11% of calls that 911 dispatchers receive have something to do with a mental health crisis. Very, very difficult to get kind of data on that because they don't often track mental health incidents. But you get suicide, you get welfare checks, and then sometimes they're CIT trained at the dispatch center, and sometimes not. But it's often difficult to figure out which of those cases are. Then you'll have a crisis line, which is run by a community mental health agency. And I'd say this is the case for a lot of CMH agencies in Michigan. They often have their own line. Sometimes they call it a crisis line. Sometimes they just call it their business line. But almost all of the times, if they're like the business is closed, it'll route to like a kind of a 24/7 crisis line that is going on. So usually there's some kind of coverage. In this particular city, this one crisis line was 24/7 and could handle calls, and you'll see very faint arrows in there if you squint. That CMH crisis line, there's a little arrow from that to their mobile crisis team, which is predominantly how they get their calls. But you'll notice there isn't really a line from this 911 dispatch center to the mobile crisis. It's not a typical practice yet. Also on that top right, you'll see the 988 MyCal. So MyCal is an acronym for Michigan Crisis and Access Line, which is it's based in Common Ground, which is in Oakland County, and it covers a vast majority of the geography of Michigan. So there's 5 different 988 call centers, but MyCal is the biggest one, and they cover this particular area too. Again, that area code issue that Dr. Watson said earlier, depending on where the area code of your phone is, that call route to the area code rather than where you are geographically. But that was kind of on purpose, right? So advocates were talking about 988, and they were folks are kind of uncomfortable with the idea of a mental health crisis center knowing exactly where you were. It kind of makes sense. If you have some issues of paranoia or general distrust, or you want to remain anonymous, it's definitely understandable how people might not be willing to disclose where exactly they are and what exactly they're doing. I think on 911, it's a little bit of a different standard. If you call 911, they will know exactly where you're actually. They have the ability to figure out exactly where you are. They can ping your phone and get a precise location. But 988, they decided not to do that. But it does result in some kind of logistic issues, right? It makes it a little harder for the 988 to connect to a local mobile crisis team if they don't exactly know where the caller is coming from. But anyways, at a 911 center, you'll see a kind of a 988 center, you'll see a faint arrow from that top right box to the top left box, right? For actively suicidal calls, they will lift that up, and it sorry about that. That was a mistake on my part. That was my headphones. But thank you for going back on that. So those are the 3 options on someone to call, someone to respond. In this particular area had police department, which is traditional police, some of which were trained in crisis intervention team. They also had a police social work model, which it does exist. So police often, or I won't say often, but sometimes hire their own social work team to go out on call. Sometimes they bring sworn officers, and sometimes they don't, to do some de-escalation and crisis intervention for many of the same reasons, right? Of they show up in sort of plain clothes, and they don't bring the presence of law enforcement, which can escalate the scenes sometimes. So there's pros and cons to that, right? So I think there's some people have kind of cultural questions of if you drop a social worker in a police department, are they going to adapt some of the problematic tendencies that can happen, to problematic views of people with mental illness or other folks that we're trying to avoid. So I think you need a strong kind of presence of social work values. I think if a lot of people are here getting their social work CEs, we talk a lot about social work values and how we can kind of maintain them in sometimes difficult environments, and that can be difficult if you're the only person at a given agency doing that kind of work. But another way to do it would be, be situated at a community mental health agency that can kind of respond with police social work, with police on a scene. But in this particular city, they have that police social work model, and they also have a mobile crisis model that run by the community mental health agency. Again, they kind of went to some youth crises, and they had some staffing concerns, but we helped this community kind of figure out who was going to which kind of call. And then you'll see a few different options of places to go. Right, there's Arrest on the far left, which we're trying to avoid. But then a couple different hospitals there. We have and the wait times at hospitals can vary a lot in Michigan. I've been in a few different mapping sessions where they described these 6 to 8 hour wait times at an emergency department for law enforcement, which is be horrible. I've also been in a different mapping session where they said it's 15 minutes and you're in and out, and it's really quick. So I think it really depends on the local level of where you're at and what the facility is looking like, and probably the day of the week and the time of the day and all that. But ideally, we have these kind of other centers that Dr. Watson was describing earlier of crisis stabilization. So this one, uh, in this particular community, they had 6 beds. They had a drop-off option for law enforcement, but the criteria really differs on a local level as well. So on this one, they had a criteria of blood alcohol level less than 0.3, which I wouldn't say meets the entire SAMHSA guidelines there, but again, your mileage may vary depending on what kind of situation you're in. Sometimes they're these crisis stabilization centers. Sometimes they're called behavioral health urgent care centers, which they don't really take the involuntary cases. They do a lot of walk-ins, and if someone's looking for resources, they have that police drop-off option as well. But there's kind of a spectrum of different walk-in places that are mental health facilities but aren't emergency departments. And I'd say in Michigan, there's more of these popping up as well, especially lately in the last, I'd say 3 to 5 years. I think there's some state money coming down the pike I know of at least 2 or 3 centers off the top of my head. I think Marquette's getting one going. Last I heard, and Kalamazoo's talking about one, and then Kent County's talking about one, and so I believe there's a few others as well. But it's exciting to see these kind of new options pop up in this sort of rapidly expanding territory. Yeah, next slide. So here's another example of map. I won't go into it as much detail. It's kind of pretty similar, but you might start to see some common threads, right? So there's a 911 dispatch line, there's a CMH crisis line. No one made any mention of the 988 center in this one, so it seemed the 988 was kind of off in its own section there. But again, the high need calls would route from the crisis line to the 911 dispatch center, or if it warranted an emergency response. This place had a co-response unit. They didn't quite have an adult mobile crisis. They had what they call like a CMH crisis team. And again, this is where that verbiage gets a little messy, right? So that crisis team, I wouldn't call a mobile crisis, but they went to the jail and emergency department as a response team. And sometimes they would do some follow-up during daytime hours, but it wasn't really the kind of thing where if I was in crisis at my home right now, I could call them and they'd show up, right? So the prominent kind of arrows that we saw were the 911 dispatch saying going to law enforcement, and if they saw a co-response would work or would be appropriate in that given situation, then they call the co-response unit out, and by co-response again meaning law enforcement and a clinician, and they track some things there. They also listed the children's mobile crisis here as well as another resource that's available. And then this was that hospital that had that 15-minute wait time, which is sounds great. I would love to be in a place with that kind of resources. So they don't quite have like a crisis stabilization center or even like a behavioral health urgent care, but the most communal mental health agencies have just offices, right? There's people with mental health specialty there, whether they're clinicians or mental health technicians or peers that are there. They can do walk-ins. I mean, it's not really built for a law enforcement drop-off, and it's definitely not built for sort of an involuntary hold. But I mean, if you're at a mental health crisis center, sometimes things go down, and it's nice to have mental health professionals that are skilled in de-escalation there as well. So another kind of resource, crisis residential. If you haven't heard about this before, this isn't really like you can't just kind of walk up to it, but it is a critical part of a crisis infrastructure in that it's a place to go, sort of we call like step down care. So it's either after an inpatient psychiatric visit, or like a mobile crisis team can sometimes link people to crisis residential. It's a place to stay for sometimes up to 2 weeks based on kind of level of care. Not use restraints, and then sometimes police do need to be there for backup. But these crisis residentials, if they have them, I mean the folks that we've talked to in crisis in Michigan, very valuable as really a place to stay after the immediate crisis. Shelters there as well. Next slide. That's all I want to do here. So this is a more rural county, kind of an example of what's going on in a place with kind of fewer people and generally fewer resources. So you got your 911, you have the 988, which is a little more involved up there, and again they have that lack of GPS, and they take on the CMH calls after hours, and the CMH does have their own kind of crisis line, and they can de-escalate some things over the phone. So that I want to specify that number 1-800 call Ruth. That is not an actual number. It's just a very nice person named Ruth who is willing to take calls from law enforcement. You'll see that line up there. So this is often the case in really small rural areas, right? You just kind of have one champion who's willing to do the crisis work or has built the rapport with specific law enforcement officers. Named John, who sees the same kind of people that they know in the community, named Jimmy, who again has another mental health issue that they don't quite know what to do with. So again, don't try to call that number in a crisis. It's just a very nice person named Ruth. But that's kind of how it is. I mean, in these small systems, and it's not great for the kind of work-life balance, right? It's not exactly great to have to answer your phone after hours or at all times of day or on a vacation. So this is one example of how system mapping is like, okay, how can we make this a little more of a formal process to try to get a more robust kind of referral system if law enforcement or 911 sees a crisis happening. What are some other options to route some crisis calls to a more robust, reliable mental health system instead of kind of depending on the kindness of one person. A particular university had a crisis line that they operated, and there's another community crisis line area that connected to some of these resources, and so we try to help kind of tie all these threads together. Again, they had that crisis team that wouldn't exactly go out to the community on their own, but if they had some kind of known shelters or known businesses, they would go. And if they know the person as well, they would show up, but not exactly the case if they didn't know you, that you can get a non-law enforcement professional at your location. Anything else here? So jail, they do have some clinicians there, but I think that's a little out of scope for this kind of crisis work there. So though sometimes some crisis teams do have a lot of responsibilities, that got to show up at the jail if an incident pops off, but and then they have the office there. So hopefully that wasn't too much detail and you kind of get a general sense of how these crisis systems flow together. It really looks different in a lot of different agencies, and it's a really valuable. I'd encourage anyone who's kind of in our mental health systems to think about how they're situated in the larger system, right? We have, especially in crisis, you're going from incident to incident, crisis to crisis to crisis. I often think about kind of how everything is flowing together. So I'd really encourage you to, if you can afford it, a few hours to kind of think about where the system's flowing, how we can sort of improve processes that ultimately support better care for people in crisis. Next slide. So we did a series of interviews. So Dr. Watson mentioned the SAMHSA guidelines, so national best practice guidelines for crisis care, and we want to find out how often are these guidelines actually being followed in Michigan. So the next few slides are some examples of what we're seeing. Next slide. So here's the toolkit, and we've got the resource here. I think we have it below and sort of the resources at the bottom. If you need kind of a quick primer on what should be happening nationwide, this is the document that I'd recommend. I think Dr. Watson was definitely a contributor on here as well, so shout out there. Next slide. So we wanted to explore with a series of interviews. I think we almost got to 40 interviews by now of different mental health professionals, as well as like traditional 911 and law enforcement and emergency departments, how well they sort of align with these guidelines of someone to call, someone to respond, and a place to go. And Dr. Watson mentioned a few of them of the minimum expectations and best practices. And so we kind of really asked about all of them and to see whether they were met. Next slide. We were trying to get a better understanding of the strengths and barriers that happened, and so we're trying to figure out kind of what is an issue statewide versus what is an issue more locally. Like what are things that local communities can sort of teach each other about crisis systems versus what is a thing we need to work on as a state that might call for a state level intervention or a policy change on a higher level. So wanted to see exactly what was going on to sort of inform, okay, what are the things we need to improve about in our crisis systems generally. Next slide. So one of the really interesting themes we found was collaboration between community mental health and law enforcement. So in both directions, both as a strength and as a barrier. So we've found some really interesting collaborations. Dr. Watson mentioned like if there's a community that has a crisis intervention team where mental health agencies and law enforcement really work together a lot on not only the training modules, but also thinking about the crisis system. We found pretty good coordination. Like, do the champions know each other and do they get along well and do they talk to each other well? And not only the champions, but also the folks sort of on the ground level, like officers and actual clinicians and case managers. Like, is there a set kind of referral pathway? And so, some like if someone's on court order treatment, right, law enforcement need to be kind of involved in that. Is that process kind of smoothed out? If there's a safety or imminent risk, is there enough trust between the two agencies where they can kind of communicate who needs to be where, so that the ball doesn't get dropped and people are left. And not only the people in crisis are left wanting more, but also the agencies. What we don't want is communication challenges, right? And that barrier can pop up as well, right? So there's certain laws about who takes someone on a petition. Law enforcement are generally involved in that, and then who's doing the transport, and communication challenges exist too, right? I mean, HIPAA exists, 42 CFR exists. Now, it doesn't mean you can't talk at all. I mean, there are things you can say and there are things you can't say, especially an emergency department that gives you a little more leeway. And it's often a thing that law enforcement bring up. That they would like to learn more about what's going on, and often the mental health agency is like, well, I can't tell you everything, but I can tell you in broad terms. That generally when you send us a referral, we do make a response. Or if one way I've heard of describing this is like if someone from at that with the symptoms that you're describing, they would often be associated with this kind of agency who specializes in that. So I think there's um, it's easy to say no, I can't say anything, but it takes skill and trust to be able to have a conversation without disclosing the critical information that you shouldn't be disclosing. And so this is all for sort of what we can say about responding without law enforcement accompaniment. Slide. Um, Perception of safety. This is something else that differed a lot in our interviews across community mental health agencies. Some described safety as just sort of what we call a paralyzing factor of like, we won't go out. It's not really our policy. We'll only go out if we know the person and if we know, like if we're meeting at a public place. But there are ways of figuring out or assessing whether a community is safe, right? Like Dr. Marcus mentioned, like Cahoots has been kind of going out as a non-law enforcement model since the 80s, right? Denver, the STAR model has been going almost 2,000 calls without needing to call for law enforcement backup. And actually, there's probably plenty of folks on this call, if you're getting CEs, that do home visits all the time, right? And that there is a real risk of something going wrong. I'm not going to lie about that. But there's also a lot of the times, I'd say the vast majority, where things are okay. So I'd say there's a lot of differences in the cultures of the CMH about whether they're willing to go out on calls. So kind of depending on what county you're at or what agency, I'd say there's huge differences there. So that was one piece there. Next slide. So some of the perceptions that we heard about calls are not being safe to go out, or they don't have enough staff, right? There's capacity issues, right? I mean, we got workforce shortages kind of across the whole economy, but especially for mental health, because it's very hard work and people generally don't get their master's degrees to work in odd hours of the night in really difficult cases. So there's naturally a lot of turnover going on in this kind of field, right? So a lot of uncertainty, people say, whether we don't know if there's going to be weapons, don't know if there's going to be violence. Well, I mean, kind of in every house you get don't mean it's scary, but every house has a kitchen, every kitchen has a knife, right? So there's going to be weapons kind of in most homes, if not all homes. And I mean, we live in Michigan. It's, not exactly Texas, but I mean, there's guns in a lot of places too, right? So big difference about whether there is a weapon in the house at all versus kind of whether it's out or being threatened with. And so that uncertainty, I think, has caused a lot of differing opinions from CMHs about whether an incident is dangerous, or whether a neighborhood is dangerous, or whether a particular individual is dangerous. I don't want to kind of brush it under the rug saying it's never a factor. And like, I think best practices, we'll have at least some kind of situational awareness training for folks going out on crisis calls. But again, having it be completely paralyzing to not go on any calls, I think, is also a problem in the wrong direction, which then ends up in people in crisis being responded to by law enforcement, which has some problematic outcomes that we know well, right? Okay, I think that's everything on there. Next slide. I think there was one behind there. Yeah. So some of the solutions to safety and price on crisis calls that we've heard about from some Michigan CMHs. So different protocols, such as checking in before and after a call. Like, I remember we were working with a post overdose program, and they had someone at the office that and then the person on the field would text before they enter, and then they'd text after they enter, say, hey, I'm okay, things are fine, and before they enter, say, hey, I'm about to go in this building, gotta see so and so, just letting you know I'll be there if you don't hear back, blah blah blah, or and they would do kind of quick text check-ins. So that was one way that they monitored safety. Another piece is they had sort of panic buttons, where it's really quick big button to call if things go down, things are really quick, kind of all automatically triggers a 911 call for police backup. Another piece they had is GPS tracking. Which sometimes it's an app on a phone you can get that kind of connects with either the crisis hub that Dr. Watson was describing earlier, or just that CMH mental health agency, where they kind of knew where folks were at, so things can keep track on, and then check in with the other members on your team, and then share what information you can with the other, not definitely with your other mental health agency employees, but then sending two people on cases, generally good practice, and being in touch with local public safety. Thanks. Next slide. So certified peers and recovery coaches. This is another theme we saw pop up quite a lot, right? So it is a best practice to send peers alongside mobile crisis teams, but we don't often see it happen. So peers, recovery coaches, people with personal experience with mental illness and mental health crises, or in the case of a recovery coach, can be including substance use disorder, who really are skilled in relating to folks. You don't necessarily need to diagnose folks in a crisis, but just expressing that basic empathy and really having a shared experience to draw from as you're connecting with people. And the story that I'll tell is back from my own experience in an MSW program, where we went on an internship, and I was working at a homeless or a day center for folks that were unhoused and get a free meal and connect with basic services. And a fight broke out, and there's a lot of yelling. It was in late August. The temperature was really hot, and someone grabbed a chair and was swinging a chair around. And I was like, I have no experience in this kind of stuff. It was my third day on the job. Did not know what to do. Kind of backed away, but really the people at that agency that were so skilled at handling that situation, they knew the folks that would come in often and could speak and say, hey, we're not afraid to break up the situation, could get some space between the two people that were fighting with each other, and say, hey, you know what road, those two roads, right? I mean, you've been down that road, you don't want to go down that road again. And it meant a lot more from that peer than it ever would from a freaking MSW intern who's new to all this stuff, right? So I just bring that as an example of the value that peers can have, not only across agencies, but especially in the roles of crisis, of being in it before, keeping your wits about you, not getting that heart rate too elevated, being comfortable with the different situation, and can really kind of talk people down and to de-escalate. Really valuable, but we don't often see it in crisis teams. Next slide. So benefits to using peers, again, what I was talking about earlier, makes things more fluid, more dynamic, enthusiastic to respond to people, really that builds strong rapport, ability to engage. But there are systemic barriers that make it harder to loop peers into these teams, right? Like the peer reimbursement code is not a lot of money. And peers themselves don't get paid a lot of money generally, and so there's a high turnover, there's limited workforce ability, and there's also some cultural stigma with clinicians, right? Like people that go through several degrees are really how can I say this? Being nice to my fellow social workers on the call, we think we know the answer to things, and then we're not often likely to trust folks without as much educational background experience, right? So I don't know. I'm an academic. I'm an ivory tower. I can say that of us, right? So we can trust other folks, especially the peers that know this, but there is sort of a stigma around trusting peers to do kind of more advanced stuff. Now, we're not asking peers to diagnose people or do any direct clinical skills, but there is an issue that can happen with if we don't trust peers enough to kind of step into roles that they're really good at. Next slide. So here is an example. How can I say this? So here are a few different sites where we tried to see how many of the minimum expectations and best practices of SAMHSA were actually being followed. So first thing I want to say on this is not a generalizable sample. These are probably 5 stellar sites. I wouldn't say this is 5 normal sites, but 5 sites that are actually doing pretty good work here. They meet a lot of the minimum expectations of a call center, right? They often have a clinician on board. They often assess suicide risk and that aligns with the National Suicide Prevention Lifeline. They often connect with the mobile teams in their area and can connect people to resources. We don't often we didn't at all see the caller ID function of knowing like who exactly was calling. It was pretty rare that we saw the GPS enabled technology, and the state of Michigan doesn't quite have a registry set up such that a crisis line can see it and know whether there's a bed available. Though crisis lines were pretty good at setting up sort of follow-up appointments afterwards. So again, this is not a representative sample. This is sort of like cream of the crop here of kind of what's going on, but it does tell us, hey, maybe at a state level, we should look at that bed registry, or maybe we should look at figuring out how we can get caller ID going. Next slide. These are a few different crisis response teams. This is again, this is sort of the best ones among Michigan. Almost always see a licensed clinician. That's usually not an issue. Respond where the person is, not restricted by locations or times. As Dr. Watson said, they're not often 24/7, and they're not often go anywhere anytime. So I'd say this 4 out of 5 is a little bit unusual, but they are very good at connecting folks to resources in the area, whether it's emergency department when needed, but sometimes a CMH walk-in office or other kind of crisis level care. Again, the peers, the mobile crisis team, I wouldn't say that's a normal. These 3 out of the 5, they had it, but it's not representable. And then going without law enforcement, unless special circumstances warrant inclusion. So like, were they willing to go out, without like a sort of a non-co-response? These 5 did. And do they have the GPS technology? Again, some did, and then they were often and really good at scheduling follow-up appointments for outpatient care. And I'd say that's generally true of a lot of the mobile crisis. Like we almost always see clinicians, and we always see the setting up the outpatient and even the during crisis care of connection to facility-based stuff. We see that pretty well across the board too. Next slide. So place to go, we haven't gone so much of this, so you'll see some question marks that this is some stuff that we're still working on, but this is just the minimum expectations. And so there aren't a lot of these kind of crisis centers going on in Michigan. I said there's more popping up recently, but I wouldn't say that they all accept all referrals, right? It's not a just take everyone policy across the board. There's a lot of medical clearance that they're kind of needed to get in. If someone has some medical needs, they got to kind of take care of that first. Usually they're designed to do both mental health or substance use issues, but again, sometimes that blood alcohol content can be higher up there, and the facility will return them away. He's got to be able to accept basic physical health needs, deliver care to more folks. It's good practice to accept first responders. It's really important for those first responders to be able to kind of do a quick turnaround and go about their way. Otherwise, they might not come back. And so we want to try to be receptive. Like the goal is to try to take less time than the jail would, right? Because unfortunately, that's a lot of options that the law enforcement are making is whether they go to that emergency department where it's there's a lot of acute care and a lot of medical care there, but they could be end up waiting. There's like a mental health facility where the care is probably more appropriate and probably less expensive, but can turn around pretty quickly, or jail. And so we want to try to avoid jail, and so we want to try to make these facilities as accommodating as possible to as many crises as we can. So generally we see good for screening for suicide risk, and they often screen for violence risk. Next slide. And these are some of the best practices. So function as a crisis receiving or stabilization facility. Oftentimes this means like, can they take involuntary cases? I'd say it's the state is sort of developing criteria for crisis stabilization units so that they can take involuntary cases. I know they're working on developing that criteria and releasing it, ideally within the next few months. So we'll look for the MDHHS kind of announcement there on whether they can call themselves kind of crisis stabilization units. But until then, we're kind of working with these other kinds of facilities of the psychiatric urgent care or receiving units. Again, really good at coordinating connections with ongoing care, but we don't often see the bed registry set up or kind of intensive support beds that work for overflow. Not as common. So that's how we're doing against the SAMHSA guidelines. We're trying to get in addition to these 5 sites, we're trying to score 5 more, and then not only assess the behavioral health systems, but also sort of the traditional response systems, like how are 911 and law enforcement and emergency departments hitting these guidelines. And so, stay tuned for more things on that. So next slide. All right. So I probably won't go through all of these slides, but this is some work that we did to look at the different outcomes of different crisis response model, like what actually happens if these models show up on scene, and what have we noticed in Michigan. So next slide. So we looked at 6 different sites where we just looked at the actual data of a few different mobile crisis models, a few different co-response models, and a few different kind of office-based crisis models where people kind of walk into offices and sort of try to look at what the outcomes were. So it's those dark green counties, and especially the white dots in those counties, where we try to get sort of a range of geographic diversity, racial ethnic diversity, and different kind of funding sources of the programs to see kind of what was going on with these crisis services. Next slide. So again, different kind of models, trying to repeat this and drive the message home, right? So we have co-response, where it's primarily clinicians going to law enforcement, calls for service, often showing up with a clinician with a law enforcement going out in the scene. We have mobile crisis, which is a non-law enforcement model, enters the community outside of a hospital or healthcare facility to serve someone in need. And then office-based crisis, this was on the diagrams earlier, but this kind of services you can get if you walk into a CMH office, not necessarily like an urgent care or a behavioral health crisis center, but just a straight up office building where we know that services, crisis services are being built. Excuse me. Right, next slide. So we looked at a few different areas to and a few different programs. And so you might be familiar if you live in Michigan to some of these sites, right? So in Kalamazoo and sort of the central CMH Michigan, we looked at their office-based crisis models. Those were the ones that they had operating as of 2021. They got a few more things going on since then, but 2021 is when we collected the data. Those middle two sites, so Jackson and Hillsdale counties, that's Lifeway CMH, and then Washtenaw County, where there's Washtenaw CMH. They had so local law enforcement as a comparison group, but again, there wasn't the actual mobile crisis model. But you'll notice in that funding, this is probably too much information to take in this whole thing. But if I were to just focus on the funding, you'll see that the Jackson, Hillsdale, and Washtenaw, you see, Dr. Watson referred to this earlier, CCBHC. So they get extra dollars to be, and they are required to do some crisis services, as well as millage dollars. So all three of those counties also passed a local millage to better support their mental health services, which gives them a lot of flexibility to offer the kind of care that is necessary. So that really allows them to go out and do the services that they need to do. And what's really crucial when we talk about what a firehouse model of funding these things is. So how do we pay for like police and fire, right? You don't have to actually bill by the service. It's a public need where we've decided that yes, if there's a house burning in our community, we want people at the ready to go respond to that fire. So that's the kind of model I would like to see of mental health crisis, right? And that's the kind of model that millages allow for as well, right? It's not just you get reimbursement by either with Medicaid or for commercial insurance, but you actually just have funding for people to just be there at the ready, waiting for a crisis to happen. So I'd say it's these kind of mobile crisis models are more feasible and available in sites that have this sort of extra source of funding. And they have some other crisis resources there as well, whether they're stepping up or a behavioral health urgent care center as well. And then on the right, you'll see some co-response models. If you're familiar with Southeast Michigan, these communities have a little more money than some of the other communities, but those police departments also put up the dollars to fund a clinician to co-respond to their services as well. So that extra local municipal funding helps to make this viable and possible. So those are the sites, and then I'll kind of show you what we've been looking at. Next slide. All right, so there's going to be a lot of clicking. I'll let you know. So this is kind of where we got our data. What we wanted to see is what kinds of calls or mental health crises were responded to by law enforcement, and what kind of calls were responded to mobile crisis. So full disclosure, it's not like we randomized what the kind of what responses were, but wanted to show kind of where we got our data from. So I'm going to tell you to click a lot of times, Dr. Watson, right? So click again. So those are all the dispatch calls in all of our jurisdictions combined, which was about 500,000. And then we narrowed down to just police reports in those 6 sites that had to deal with mental illness. And we used some key search terms, and I won't go into the weeds of exactly how we picked those out, but it was tricky. But we got about 2,500 calls, and you can click again. And some of we excluded the youth, and we looked at a randomized sample of police reports. So of that 2,500, we narrowed it down to almost 800. Next click. And so we then separated out by what we call sort of a live response to crisis, or Watson said kind of hot crises versus those that were just pickup orders and medical emergencies, because we know kind of pickup orders, medical emergencies, those generally have to go to emergency departments. But with this study, we kind of wanted to find out, what happened on scene. So looking at that 617 number. If you click again, we'll start to look at the data coming from the mental health side. So incoming requests to a CMH, almost 72,000. If you click again, then we'll actually look at the crisis services. And if you're familiar with billing codes, it's like the H2011s and the T1023s. So like crisis services and then pre-screening for hospitalization were the codes that we used. If you don't know what those numbers are, don't worry about it. There's mental health crises. Click again. We took a random sample of that because reason we need a random sample is to actually figure out what happened. We had to read the narratives, read what each clinician wrote to figure out where they went, because the data is not very good. So we didn't want to do that for thousands of cases. So it's okay, we'll do this for hundreds of cases. So we got 719. Again, we took out the cases that were strictly at the emergency department, and we took out the cases that were youth, because that was just the IRB thing that we had to handle. So next slide. And then we also differentiate, right? Was it a live or hot response? We had 459 there, or was it a follow-up response after the crisis went down and the CMH kind of did follow-up services? So this is kind of the why. I'll kind of call out these numbers as we go along. So next slide. Okay, so who were in our samples? So there's a lot going on here. I'm not going to talk about every number on this slide, but on the left, you'll see the ages, right? So on that green, you'll see sort of the census data from the counties and cities that we worked in, right? Pretty evenly distributed. But if you look on the left, you'll see the law enforcement crisis and the CMH crisis skewed young. So you'll see the most common bars are the 18 to 28. And if you're in the crisis field, you're probably like, yeah, there's a lot of young people in crisis. And we cut off at 18, right? So I believe that if we had under 18, I would hypothesize we would have even a higher bar there. So a lot of young people in crisis was the main piece. On the right, kind of we were wondering kind of what insurance folks were billing. This is sort of skewed because we took to the CMH sample, and a lot of people involved in CMH services are going to be on Medicaid anyway. So it's so again, not an idealized perfect sample, but just generally among people with known insurance types, which is the CMH, predominantly Medicaid in our sample. Slide. So how often were these different model types able to link with ongoing services after the crisis, right? So we have our three different types on the left there. We have our office-based crisis, mobile crisis, and co-response. Really, that office-based and mobile crisis look pretty similar, right? So about half the time, and even co-response, about half the time they were able to set up a follow-up appointment after the crisis, right? And for office-based mobile crisis, a lot of the other times, if they weren't able to set up an appointment, they're at least able to give out resources, give out a phone number, give out a card, at least mention the thing that they can do next, right? Happened a little bit less in the co-response model, but generally, when a clinician is on scene in any of these kind of CMH models, we're pretty good at setting up the next thing to do. Whereas in the law enforcement side, if you look on the right, usually their standard of doing that is to tell the emergency department and say, okay, done my job, which I understand. I mean, as a law enforcement officer, your job is to go from case to case to case, and so when you're done with emergency department, you kind of move on to the next thing. But unfortunately, for those of us that are in the mental health system, we kind of know that there's often a disconnect between emergency departments and sort of the next thing that needs to happen. So most of the time, it was ED only, or 28% of the time, there was no linkage attempted to kind of the next thing. And so but 10% of the time, they did notify the CMH about kind of what to do afterwards. Sometimes that was a live call out of actually bringing people to the scene with them, or at least a referral post-crisis to the CMH afterwards. So in general, when these kind of models, whether it's mobile crisis, co-response, we see good things kind of happen in Michigan in terms of connection to ongoing care. Next slide. Non-billable follow-up contacts, I won't get into this too much, but generally co-response models, that big 71 number that's probably popping out at you, that means like about 71% of the time they made at least one follow-up attempt on a crisis, right? Whereas the mobile crisis in the office-based, sometimes they wouldn't do any, but sometimes they actually did 3 to 9, 10 plus attempts at non-billable follow-up attempts, which is good, right? A crisis doesn't last one day, right? So we often like to see these kind of ongoing engagement after the crisis in the weeks and months following the event. So some positive signs here. Next slide. We wanted to see among the law enforcement reports how often threats were being made either to oneself or one's others. And the way we determined this was reading the law enforcement description in the police reports, which, take that for what you will. But essentially about half of the cases, a little more, folks were making threats to themselves, and about 20% of the time making threats to others. Sometimes it was both. But we thought it was worth documenting, how dangerous are these calls. And granted, these are crises this is a sample where a law enforcement actually had to write a report on the incident. So there's a lot of cases that just don't rise to that level of severity. And so we're probably looking at a more dangerous sample than usual. So that'll inform this kind of next slide, where we look at incident escalation. So we looked at among the office space and the mobile crisis, calls. How often do they need to call 911 for backup? We didn't include co-response because kind of law enforcement was already there as a backup. But generally, it's not often. It's 3% of the time for the office space and 7% of the time for mobile crisis. Didn't need to call 911. Next slide. So this, I want to preface, right? This isn't a clean apples to apples comparison, right? So these are the law enforcement calls that are coming from 911, right? Versus the community mental health calls that either, are either walk-ins or they kind of know the numbers. So I can't say that it was because the law enforcement that things got out of control, right? But we can look at the incidents and see what happened, right? So we're working on trying to make this a little more robust and getting some stronger comparison groups. But what we can say is among when the co-responder was on scene, about 7% of the time there was some sort of use of control or force, and we include the handcuff use there. And then some of the law enforcement saying that's not quite use of force, but I was like, it's something, so we should document it, right? So 7% of the time on the co-response and about a quarter of the time on the law enforcement only cases. There was a use of control or force, most of that being handcuff use, but some of that being empty hand control and less than lethal. Generally, women were less likely to have force or control used on them than men, and the average age of people among whom force was used on was younger compared to not, which I guess makes some sense. But in general, we hope to see less use of force and hopefully co-response can be less escalation from that. Next slide. Transportation. So this is probably the most interesting, and of course I say the most interesting thing for like an hour into a slide of talking about a lot of stuff, right? So transportation of where someone was brought brought after the crisis. So law enforcement traditionally bring folks to emergency departments, whereas office-based and mobile crisis, most of the time you see 23% able to resolve on scene. So that means we're using like less acute resources for care downstream and kind of avoid the more serious mental health resources and more expensive resources for the person, the more we're able to de-escalate on scene. The co-response, you should say that there's that transported to mental health treatment. They did have these sort of the special treatment centers in those particular areas. So there's a little confounding there. Exactly, not apples didn't control for everything. So you'll see there. Arrested, there's 3% of the time for the co-response and law enforcement. But yeah, I mean, most of the time the folks with the incidents with a mental health professional on the scene was able to resolve informally without having to go to an emergency department or mental health facility, kind of resolve on scene. Again, not apples to apples comparisons, right? These are law enforcement cases coming from 911 and community mental health cases with crisis lines. Can't say they're all equivalent, but at least it's a positive indicator. I think should mean something, even though it's not as robust research as it could be. Next slide. So just underlining the point, a lot of informal resolutions for these office-based and mobile crisis cases. Next slide. And that emergency department. So among those that were taken to emergency department by law enforcement, 70% of the time it was involuntary. So a good chunk. There was some coming voluntary. Some it was unclear. Some of the language was not as clear. So we were using the police report narratives on whether it was voluntary or involuntary, and we had to kind of look for language. So mileage may vary, but generally there was more involuntary cases than involuntary when law enforcement would take them involved. So next slide. So that's a lot of talking. I hope some of the message came through. So the mobile crisis and the co-response models generally had funding outside of Medicaid. They were able to do these kind of non-billable services. So whether that was CCBHC money or county millage money or from the municipalities, they were able to kind of support these extra models where folks were able to get non-law enforcement responses out in the community. Folks in crisis tended to skew young, so we got a lot of more as a research center, we got to look a little bit more about how youth crises are being handled. Compared to law enforcement responses, the CMH we're pretty good at connecting people to ongoing care outside emergency departments. Again, there's the caveats for comparison groups, right? Not ideal apples to apples with all the control variables that we can, but generally the internal referrals, more informal resolutions than the law enforcement calls. I think that's everything. We have some resources here. The national guidelines for behavioral health crisis care. There's a link. I think these slides are going to go out afterwards. I refer to it at least every week, if not most days of my week, just to check back on what the crisis systems should be doing. There's a great crisis jam. This is Wednesdays at noon. It's a national learning community. It's good to check out. We also run our own kind of Michigan crisis response community practice. That's every first Friday of the month at 11 p.m. That's actually, we have one tomorrow at 11 a.m. if anyone wants to hear more of this kind of stuff. Email me. It's an open group if you're kind of a practitioner in this area. Love to hear your experience and feedback. And then if you want to see some of our other research and reports, there's all more stuff to make your eyes bleed on that website at the bottom there that you can kind of click on. And I think that's everything. I think we have some references. I don't know, Dr. Watson, if you have more to say or more to wrap up.
Thank you, Amy. Thank you, Leonard.
Right. Understood. And I guess let me stop sharing for a moment. And I don't know if we have any questions. We have a minute or two. If people have any questions. I see one comment that it would be helpful for slides to be able to download, and I believe those will be made available after we sign off of the webinar.
Thank you guys for this great presentation, and thank you everyone for learning with us. You guys will receive your CE certificate in the mail within 5 to 7 business days. If anyone has any other questions, please ask now.
Is there a quiz we need to take?
You would get it in your email.
Okay, great. Thank you.
No problem. No, you guys don't need to sign up.
Well, there's no questions. Thanks all for being here. I know you could be in a lot of different places, but I appreciate you're willing to talk about crisis, or at least listen to us talk about crisis.
Yeah, and thank you. And if people have questions later, my email is on the Wayne State website. Leonard put his in the slides. I'm sorry I didn't do that. But the CBHJ is a great resource for information crisis services. So check out the website as well.
I think we're good.
All right. Thank you.
Thank you guys. Thank you so much. It was a great presentation. Bye-bye.
Take care.
You too.